What's going on, Macro Perspective peeps? Oof, man, what a great episode I have here for you. We have an amazing guest, Dr. John Neustadt, coming out of San Diego. I want to just intro here real quick because the plethora of work we're about to have is amazing. So make sure for you guys that are listening, maybe grab a notebook, put your Otter AI on and start transcribing a little bit, because what's going to happen today is a little bit of a clinical thing, but really important for men and women kind of in their middle ages. But today, Dr. John Neustadt, he's the founder of Nutritional Biochemistry. By the way, I love that word biochemistry. It's probably one of my favorite words and what it means. He's spent over 2 decades as a clinician, a researcher, a writer, and entrepreneur. His products, as well as supplement products, have been shipped to over 15 countries. He's been published more than 100 plus research reviews and, lectures frequently at medical conferences. He's done the last 3 months of travel, which is insane. We were just talking about that right before this. But he has his latest book, which is Fracture Proof Your Bones, a comprehensive approach to osteoporosis. I think this is going to be probably the topic we're going to be talking about a lot today, the lifestyle, the practical applications, and just kind of what he's found in his work. But I just want to say, Dr. John Neustadt, thank you so much for being on the podcast. Really appreciate your time.
Thank you for the opportunity.
So, one of the biggest things, when we come onto the pod, we really want to highlight the person and what got you into the field first and foremost. What got you interested into doing all of this for the field? What was that pivotal time for you? Did you just go to school and you're like, all right, I am going to write 100 plus research reviews? Or did you go, you know what, let me just find my passion, and then you kind of stumbled into this? How did that happen?
I know I kind of stumbled into it because I and I went to my conventional medical doctor. I was working at the time at my tech. In my 20s, I was a project manager at a software company, and I started to not feel well, and I did not like the service that I got from my medical doctor, who I didn't know, by the way. I just picked him out of whoever my insurance company would cover, I think, with a lot of people. And he walked in the room. The first thing he had, I noticed, is he had his prescription pad out already. He asked me a few questions. Within 3 or 4 minutes, he was ready to write me a prescription and move on to the next patient. I had questions, though. I wanted to understand how my body worked. I am by nature insanely curious. I like to understand how things work. I like to understand what I can do for myself. And he was not prepared or able to do that, I think, for several reasons. One, the insurance model under which we all exist in this country necessitates that physicians see a high volume of patients every day. So he was ready to move on to the next patient. He just wanted to write his prescription. He literally told me it's just something I have to live with, which I did not accept that answer. And I left there. I also understood that at the time, medicine is an industry. And like any service, if I don't like the service I'm getting, I am free to fire that provider and go find somebody else. So I had heard of Bastyr University, which is a naturopathic medical school in the Seattle area where I was living at the time. And I decided I would give these people a try. I had known a few students who went there. I was impressed in my conversations with them. And when I went into the appointment, I was struck by a couple of things. One, it wasn't rushed. No question that I asked was off limits, meaning they didn't seem impatient or that they didn't want to answer it. They educated me about my own body and what I could do to improve my health. And the attending clinician, the physician who was overseeing the 2 students, got to know me so well in that first appointment, which is about 45 minutes, that he looked at me at the end of it. And one of the philosophical underpinnings of naturopathic medicine is treating the underlying cause, not just masking or suppressing a symptom. So he got to know me so well that at the very end of that conversation, he said, "You need to quit your job." He recognized that the underlying cause of what was going on with me was chronic stress, by being partly or largely in a profession that I did not like. I was miserable in, but I had golden handcuffs at the time. But that was, at that age, I think the third party validation, hearing from somebody else, getting permission from somebody else, something I needed to hear that I knew already I needed to do. So the next week I left that job in that profession, never looked back, and started applying for medical school. And though in terms of my writing that you mentioned, that was not my first sort of time or profession. I was a journalist. One of my undergraduate degrees is in writing and literature. And that's one of the ways in which I learn. I love to write. I love to research. And if I can explain something through writing succinctly, either to professional publication or general public, that's when I know I finally understand it. So for me personally, writing and that process of writing is a way of distilling down knowledge. And so if I can communicate that in a way that is effective, that's when I know I finally understand it.
Yes, because with like journalism as a whole, right, it like really has to like engross you in the processes that you're trying to go about sharing with like a greater audience, right? So I can see how that would be like something that it would tie you to it a bit more. And then, like you just said, like the golden handcuffs or the sunken cost fallacy in certain situations, I feel like a lot of us can kind of just succumb to like it's easy and convenient and also pays well, right? But then you're maybe not living your best life. And I mean, kind of why we started this in a sense is to be able to kind of extract that wisdom from a bunch of different people, but then also like leave with like actionable things and hopefully leave the audience with it too. So yeah, so like how many years was that inside of that organization?
Which organization?
For the previous one, the one that you said that was the but with the golden
company?
handcuffs.
High tech. So it was various. I was about 5 years doing that. It was after college, after a second degree. See, part of just my personality innately is I, like I said, I like to understand things. So I was a journalist actually overseas in Chile and then in San Francisco. And I wanted to do environmental writing at the time. I was in Chile. I wrote for a little bit for an environmental or an economics monthly publication. And then in San Francisco, it was a twice monthly English, Spanish language newspaper at the time. And I became the editor of that. But I really wanted to do environmental writing, but I didn't have a science background. And I wanted to be able to access and understand the primary data because I was concerned if I did not, I would be more open to manipulation from the sources. I couldn't read the studies to verify or contradict what somebody was telling me.
Yeah.
So I went back to school and I did a whole nother undergraduate degree at the University of Washington in the sciences, and botany was my second undergraduate degree, a BS in botany, where I did all my pre-med at the time. But then when I got out of that, I did not want to be a journalist anymore. I didn't want that lifestyle. And I just fell into that, first marketing and then technical writing in the software industry at the time. Jobs were very plentiful in that in the Seattle area. So I did that for a while before going back to medical school.
So then why bones?
Great question. Because my mother-in-law had osteoporosis. And when I was seeing patients in Montana, my clinic was in Montana, and I was a baby doc, fresh out of practice. I was doing what, I think all new fresh-faced doctors do is we do what we were taught. And so I was focused on bone mineral density, and I was working with some patients who had osteoporosis, and their bone mineral density was going up using these integrative approaches that I was taught. So I was happy. And my mother-in-law at the time had osteoporosis, and she just passed away last September. And so, but she lived to 93. And this was just last year she passed away. And when I was working with her initially, this was 20 years ago when I got interested in bones, because I was helping her with some recommendations for diet and exercise and a little bit of dietary supplements. But she had her physician who had her on Fosamax, and her bone density was going up. So her physician was happy, she was happy, and I was happy. But then she tripped on a throw rug in her house and broke her hip. And I thought to myself, something is wrong with this picture. So I started looking closer at the research and trying to understand this disease. And I was shocked by what I discovered, that myopic, nearly universal focus only on looking at bone mineral density and treating and tracking bone mineral density is leaving a lot of people dangerously exposed to problems, because a bone mineral density test, as it turns out, and we've known this since the 1990s, predicts less than half of people with osteoporosis who will fracture. And yet, like I said, it's almost exclusively the only thing that's tested and tracked.
Mm-hmm.
And in 2008, another study came out that refined that knowledge a little bit more, and showed that for women with osteoporosis, it only predicts 44% of women with osteoporosis will fracture, and only 21% of men. And if a woman gets osteoporosis and breaks a hip, there's up to a 36% chance that she's going to die in a year. If she has breast cancer and ends up fracturing, and she has an 83% higher risk of dying than a woman with breast cancer who doesn't fracture. Osteoporosis A woman's risk of an osteoporosis fracture is equal to her combined risk of breast, uterine, and ovarian cancer. Osteoporosis fractures account for more days spent in the hospital than other conditions like diabetes, heart attacks, and breast cancer. And if you're a man and you fracture, your risk of dying is even greater than a woman's. And so that's where I became quite passionate about this, of trying to move the needle and help clinicians and the general public understand, look, we've got to move beyond bone mineral density.
Yeah.
The number on a test is not the most dangerous thing about this condition. It's whether or not somebody breaks a bone. So we have to reframe this conversation around fractures. Every question around treatment, around prevention should be around fractures. Is what I'm hearing, is what I'm being recommended, has it been shown to reduce fractures?
Yeah. Yeah, it's a really great point. I just want to highlight that for a second. All these percentages and statistics are amazing. I think for the listener, what was crazy there to me, what really popped out was ovarian cancer, other cancers, and diabetes. Like, there's more time spent and more money spent on bone issues in the hospital. That's crazy to think that, because the way Marcos and I see, just the work we're dealing with, and just kind of like what the news talks about is like obviously obesity, pandemic, and all these different things. My head wouldn't think a bone mineral density thing or like a fracture issue.
Well, and every 30 seconds somewhere, someone is breaking a bone with osteoporosis. It's second globally only to cardiovascular disease as a global health problem.
Every 30 seconds. So is
every 30 seconds.
Almost as frequent as a car crash? Isn't like every 15 seconds for that?
Well, that's interesting. I don't know about that, but yeah.
That's probably from the car crash, Marcos.
Well, okay. So my mind went a few places, like as you're rattling off the stats again, because if bone mineral density isn't, we'll call it quote unquote the gold standard, or if that's like the easiest test to kind of provide to patients in a sense, which even then you're not typically getting it done at a normal doctor's office, right? What do you look at then? Like, as obviously like Seamus and I were both like ears perk up. Well, we're doing these tests. We're looking at the hip. We're looking at we're looking at T-scores. We're trying to like
Z-scores,
convey messages over to our patients that we work with. But then you're mentioning that there's another way of looking at this that's probably a better solution, Mark?
Well, in addition, I would say.
Okay, in addition.
The gold standard for testing is still the bone mineral density test. It's the best technology we currently have that's widely available and covered by insurance. And every new technology that's out there is compared against the bone density test. Despite the limitations of that test in terms of its ability to predict fractures, people should get it done because it's one piece of a much larger puzzle. But the challenge is people go into their physician, they get this test result, and the doctor immediately, and I've heard this over and over again, says you need a medication, you're going to fracture, and the person is just frightened. They're scared. And when they come to me, they don't know what to do. They are afraid that they're going to fracture and die or end up in the hospital. And first thing I do is have them take a couple of breaths and calm down. And I put that test in its proper perspective, and I tell them just what I already said. How it predicts less than 50% of people who will fracture. Fracture risk depends on factors largely other than a bone mineral density. So let's take a couple breaths. This is serious, but it's not an emergency. There is time to put together a holistic program that makes sense for you.
Yeah. And real quick, I know we're talking about this test. Marcos and I are pretty privy to this. We talk about like a DEXA scan. Is this primarily the testing that a lot of people get? Because DEXA scans have gotten really popular over the last few years. People come in, they look at their bone mineral density, but a full body scan is not everything. You need to look at the L1 through L4, like a spine. We look at the hip. And then obviously there are T-scores and Z-scores. But I think there's still some limitations in that too, that depends on the technology. Like if you're using an older technology, like a GE Lunar, as compared to something like a Horizon Hologic. And then even with that too, some of the population bases, right, John, are from like NHANES 2008, or like not even an updated population study. So would you mind just covering that real quick?
So some of the limits. So I think one of the most important things is consistency.
Okay.
To me, it doesn't really matter which machine they use or which testing center they use. What's important is that they go back to the same testing center and they use the same machine, because that consistency, machines can be calibrated differently. Just trying to get consistent results time after time allows us to compare past test results to more current ones and see trends. A lot of this is trying to look at trends and where things are moving. In terms of what you talked about or alluded to, I would say sort of eligibility criteria. There are some people for whom a DEXA scan is not something that is good to get, or the results won't be accurate enough. So if you're too thin, or if you are obese, too heavy, there's a cutoff for the weight limit of what the table can support in terms of these laying on the table to get these scans done. If you have arterial or abdominal aortic calcifications from cardiovascular disease, because the DEXA scan is an X-ray and the X-rays pass through the tissue and hit the bones and they strike minerals, they bounce off the minerals, and then that's what's detected. That if there are calcifications in the artery or in the vertebrae, for example, if you have vertebral stenosis or arthritis, where there are calcifications on the bones, that can give abnormal or inaccurate results. So there are just some things, some criteria that, the technician and the physician should hopefully be checking for to make sure that the scans that people are getting are as accurate as possible.
That makes me wonder. Yeah, you're right. The limitations for like obese people. I mean, most tables, your table, Seamus, holds 450?
450. But the problem isn't the weight. It's sometimes the width of the person and like the length of the person.
Yeah, positioning could be a problem.
It's just the positioning. Yeah, exactly. And it's like, sometimes they make these beds more for the athletic populations and bigger populations. And I think that's what they're doing because they're like, the population is getting bigger. But even then, I'm like, still not big enough.
But John, are these studies specific to the hip density? I would hope.
So I'm not sure what studies you're referring to.
The ones you're quoting with regards to like the percentages.
For fractures?
For fracture risk. Or is it just the total body?
So it's just looking at the predictive value of the bone density test results for fractures overall.
So how would that work? So like logically, I would look at this, and the problem I would look to solve is specific to density of the hip. But it sounds like this study may not be that specific.
So it did not, try to remember back, it wasn't that specific. But here's another piece of the puzzle. To me, that's not really as relevant as I think the overall idea of what bone density misses, because it can't detect the quality of the bone. So for example, even if you look at, it doesn't matter if you're talking about the hip or the spine bone density. When somebody takes an FDA-approved medication for osteoporosis, changing that bone density test number is not an indicator that their fracture risk is being reduced. So improving that test does not correlate with reducing their fractures. And this is what different studies show. Even the American Academy of Clinical Endocrinology, their position statement on osteoporosis medications is that the change in bone density accounts for less than 20% of the potential reduction in fractures.
Okay. So that practically meaning like, is there any reason as to why to then take it then? Are there any like side effects too with those?
So, you talking about the testing?
No, not the testing, but like the medication that is not even as 20%.
So there are, but first I do want to say that, a lot of people hear when I've said that, the question, which is why I asked to clarify, is, is there any reason to even take the bone density test then, if changes in it aren't even that predictive? And I think the answer is yes, because oftentimes it's the only thing that indicates that somebody has a problem. Because this is asymptomatic, you don't necessarily get bone pain or any other symptoms. And so these tests, one of the most important roles they serve, whether it's a bone density test or another one, is to start the conversation and make somebody aware and hopefully get them more motivated to improve their health and do something about it. In terms of medications, the question that I always ask is, do they reduce fractures? And the answer is yes, medications do reduce fractures, but the challenge is that they don't reduce all types of fractures equally, like vertebral versus hip fractures. So if you've never fractured a bone before, and it's called primary fracture prevention, and you have osteoporosis, the research shows that only one of the medications so far has been shown to prevent both primary vertebral and hip fractures, and hip fractures are the most dangerous. All the other one, and that's Zometa, also called zoledronic acid, or reclassed, and it's by intravenous infusion. All the other ones, the oral bisphosphonates, that is a bisphosphonate, or Prolia or Xgeva, any of these other ones have been shown to only prevent primary vertebral fractures of the spine in postmenopausal women with osteoporosis, which is what most of the research is in. Now, if somebody's already fractured, they already have osteoporosis, have already broken a bone with osteoporosis, then you have a lot more options. Medications are more effective at preventing both vertebral and hip fractures. But the problem, one of the challenges is you've got to stay on it long enough. The first line therapy for osteoporosis are still the oral bisphosphonates like Fosamax. And over half of people discontinue that medication within the first year because of the side effects and how difficult it is to take it and stay compliant. You have to take the medication 70 to 80% of the time to get the clinical benefits. And so it's just challenging. Somebody has to really commit to taking it. And, there are other medications that could be helpful, but they all have their own limitations and challenges.
Sounds like, one, the data feels weird. Two, the type of quote bone that's depositing that would be, like you said, trending upward in this is obviously not. There's different types of bone. Correct me if I'm wrong.
So, well, there are different types of bone in terms of what I mean. There's long bones, there's sesamoid bones, there's flat bones.
Isn't there like the actual interior part is like spongy and different than it is like the exterior? Correct.
Yeah, there's trabecular bone and then there's cancellous bone. And what happens with the oral the bisphosphonate medications is they tend to they poison a type of cell called osteoclasts, and those break down old worn out bone. And then the osteoblasts build up new healthy bone. And that process called bone remodeling is necessary for healthy, strong bone. You've got to have that about every 10 years, bone is totally new. It turns over completely, and it's basically all new bone. And what happens is it stops the osteoclast activity. And so you're not getting old, worn out bone broken down that needs to be broken down and recycled. And instead, you're just getting new bone layered on top of it by the osteoblast cells. And it's not being put, created in a natural pattern. And so it actually, after 3 years of taking this, or it can start to increase somebody's risk for what's called an atypical femoral fracture, meaning it actually increases their risk of breaking a bone. It's a very small percentage of patients, but it's clinically noteworthy, and it's definitely something to know about, and it limits how long somebody should be taking the medication.
Yeah.
But because, look, I think part of the problem with all of this is that a lot of the focus is on bone mineral density.
Yeah.
But the bone mineral density is not what gives bone its ultimate strength. It's the proteins in bone, the collagen in bone, the connective tissue in bone. Bone is a tissue. Like all tissues in the body, it's made up of different things. And the minerals are just one part of that. But it's the collagen in there, specifically that bone collagen, type 1 collagen, that is very flexible and strong. Strand for strand, collagen is stronger than steel. It's what the minerals bind to, and it's what gives bone its flexibility and allows somebody, if they fall, to absorb the force of that impact over and disperse it over a larger volume of bone. And the bone can deform a little bit without breaking. And if you were to take a chicken bone, for example, and you soak it in vinegar and keep changing the vinegar out every couple of days, do that for maybe a week, all the minerals will be pulled out of the bone. And what you're left with is the bone collagen and the proteins in the bone. And it is indestructible. It's like a rubber chicken bone. You can stomp it and hit it, run over it with a car. It will not break. But if you were to take all the collagen and remove it from the bone, it is brittle, like chalk, like a column of chalk. And that's the difference, and why you don't get more fracture reduction predictive value, or you don't get a better prediction of fracture risk with a bone density test, because it doesn't measure the connective tissue in bone and how healthy that is.
Okay, I see. So that's why when I make my bone broth, I can break
Exactly.
my chicken.
Yep.
So go ahead, Marcos.
Well, okay. Obviously, like leading into the next question, I'm sure Seamus is the same one. But so then what are the necessary steps from the holistic lens? Because now it seems like you're advocating for potential collagen supplementation. And then, what are our next steps? How do we improve upon it? And obviously that's what you've made a career out of, right? So that obviously for me and Seamus is like really important, because we want to be able to disseminate this information to our patients that do come in and, again, probably not as in depth as this, but like, hey, we need to be doing this because you do have this reading and we want to see improvement.
Yes, exactly. Like there are two pieces to this puzzle that I evaluated that I talk about in my book. And, people go through these chapter by chapter questions that they can ask their doctors and ask themselves. And one of the really important things to do is an evaluation of what medications they're taking. There is a long and growing list of medications that destroy bone. And so the first sort of half of this equation for me is what in your life might be contributing to this going on, and can we minimize that, reduce that, or get rid of it to stop the destruction, while then on the other side of the equation we're doing things to build up that healthy bone again. So some of the most commonly prescribed medications, and by the way, this is a total blind spot for physicians. Studies show this. They're just not doing medication reviews. They don't understand the medications they're prescribing are destroying bones and increasing fracture risk. Serotonin, SSRIs, antidepressants, given out like candy, and a lot of women specifically are taking them. We know now that for taking an SSRI like Lexapro, Prozac for depression, anything that artificially increases serotonin, that for every 19 women taking that medication, and the dose does not seem to matter, for more than 1 year, 1 to 5 years, for every 19 women taking it, we'll expect 1 to break a bone.
Oh, man.
There are serotonin receptors in bone. The vast majority of serotonin is not in the brain, where 90% is outside of the brain. And the serotonin receptors, when they're activated, when there's excessive serotonin accumulating in bone, it stimulates osteoclasts, that cell that I talked about that breaks bone down, and it keeps them around longer. So that's something that really is important to look at. The other thing too are acid blocking medications, especially as people get older. A lot of people are on proton pump inhibitors to block acid from acid reflux. Most of those prescriptions are because of acid reflux. And even just 1 year of taking it increases somebody's risk for an osteoporosis fracture by over 200% compared to somebody who's not taking it. So those are really important. And there's a long list. There are other medications too. So anything we can do to minimize that risk, get them into more, holistic treatments with a functional medicine doctor, a naturopathic doctor, maybe get to the underlying problem so they don't need the medication, switch to a safer one, reduce the dose. So that's a really important piece of this puzzle. The other thing then to look at is in terms of making sure that you're building stronger bones, that people are restoring that healthy balance to bone is diet. That Mediterranean pattern diet, Mediterranean style diet, which is primarily a plant forward diet, is associated with a 20% reduction in osteoporosis and a 21% reduction in hip fracture risk.
Love it.
The closer somebody can adhere to that, the better. Now, one of the challenges in communicating that to patients and people, and what's missing often in these discussions, is the amount of protein. And I see this over and over again, that when people, even when they're following this sort of more of a Mediterranean pattern of kind of blue zone pattern of eating, they're still not getting enough protein, despite the high protein keto paleo craze that's in our country. And people, there are 180 to 200 proteins in bone, in addition to the collagen. So it's highly protein dependent. The amount of protein somebody eats can account for 2 to 4% of bone mineral density, that alone.
Wow.
And the US RDA for protein as people get older is insufficient to maintain muscle mass and maintain bone. And so I like to tell people the minimum amount of protein they should get is take their body weight in pounds and multiply it by 0.6. That's a minimum grams of protein they should be getting a day, and combine that with resistance exercise done safely, of course. And that combination is powerful at rebuilding bone and also building up muscle and strengthening muscle. Because every centimeter of muscle that is lost, a muscle mass that's lost in the leg, in the thigh, is associated with a 4% increase in risk of all-cause mortality, dying from any cause. So the more we build and maintain muscle strength, the better off we're going to be. And also it'll help prevent falls, and 95% of fractures occur because somebody falls.
Oh man, I'm just going to highlight that real quick. John, that was amazing. Just rattled off these awesome things. I think the biggest reminder there is definitely take a stock of your medications. I mean, he only listed 2 out, but there's a bunch. And I think a lot of people in this country, specifically around our audience, is like, you get a disease state around your mid 40s, and then you're just taking that medication for the rest of your life, but you don't even know that, hey, like you said, there is no symptom with bones. Like you can't feel it. So now it just happens. But now we know, hey, we can get around that. And I think the biggest thing there, Marcos, and I definitely agree, right, Marcos, with the protein diet, the Mediterranean diet being one of these mostly studied diets, these blue zone diets, and even just that protein.
Yeah.
But I think you alluded to something else too. But Marcos, go ahead.
Well, I think in this context too, like Mediterranean diet doesn't just simply refer to the food anymore. Like the reason why the Mediterranean region as a whole is so health promoting is the physical activity that's a part of the culture as well. So like, again, if you think about the average, like little Nona, walking around in Italy, and or someone in Greece, like they're walking a tremendous amount. So like for people to overlook just like the structural load they're probably putting on their system, even if it's not like rucking or anything like that. Like I would like to point that out as well, because yes, the food is great, but the lifestyle also I think contributes to many of the things we're talking about here.
Yeah, for sure. I think the lifestyle definitely contributes. I think the walking around. I think there's a book a few years ago came out, Exercised, where they talked about how walking shaped our hips and bones because people were getting lots of steps, not just 10,000 steps, but lots more than that from our Paleolithic times. But John, I think you alluded to something else too, the falls. Falls are insane, but there's something that we talk about in resistance training. Maybe I'll cue you up here a little layup, but preventing falls, avoiding falls, like what can people do for that?
Yeah, great question. So one is, first of all, in terms of predicting fracture risk, gait and mobility is one of the most consistent predictors of fracture risk, more predictive than a bone density test. And so making sure somebody is steady on their feet is crucially important. Making sure that their footwear, if they pronate, I was just talking to somebody 2 days ago who is concerned because her bone density has gone down. And so she's trying to do her best. And I actually met her in an exercise class that I take. And she was great, 78-year-old woman. We started chatting. But she's concerned. She's doing a lot of walking also, but she started falling. And so I asked her a simple question. I said, do you pronate? And she's like, oh my God, yes, I do. I said, well, have you had your footwear checked? Do you have an insole? And she didn't. Simple things like that. I love simple solutions. Fracture proofing your home is really important. Most falls occur at somebody's house. So making sure that walkways to the bathroom, if you get up in the middle of the night to go to the bathroom, are well lit. You can go to Lowe's or Home Depot and get a little plug-in, something that plugs into a socket along the floor, the baseboard, that's motion activated light, so that lights up. So the walkways when you're going to the bathroom are well lit. Grab bars by the toilet and in and out of the shower in that area, important to, if you lose your balance, making sure walkways are clear of clutter. And throw rugs, like my mother-in-law's, I told you she tripped on a throw rug and broke her hip. Or that even end tables, coffee tables, there's no corners jutting out that somebody could catch their leg on and take a tumble. That loose steps are fixed. Simple things like that can be done that really don't cost money at all, and are phenomenal solutions for preventing those falls.
Yeah. The first thing that came in my mind is, so on top of the DEXA scans we do, Marcos, we do the PHI scan, which is a 3D musculoskeletal scan looking at vertebral load, joint kinematics, and also center of gravity. But it looks at the foot pronation, inversion, and eversion. And it's like you can always tie those two things together. Look, we've looked at your bone mineral density. It's low, but we've looked at your gait and your posture, and that's not looking really well too. And then on top of that, we do a balance test, a single eyes closed balance test. And it's like, we're really at risk here for a fall right now. We need to work on all of this together to make sure you don't.
I wish your approach is what every clinic, every doctor, every healthcare provider, PA, sports medicine doc, PT, that everybody did that type of an assessment.
It's so funny though, because I was about to ask that. Is there a better test than what we're doing? Because after decades of doing it, in a sense, it could start feeling stale for some of our patients. Granted, it's like, again, it's data and it's easy to collect, but do you have a recommendation out of curiosity of like a better way of assessing like quote unquote balance than an eyes closed single leg test?
Well, it doesn't have to be eyes closed. You can do it, with your eyes open, just a single leg, 10-second standing on a single leg put the foot on the back of their, kind of other calf and just see if they can hold that. Getting up for me, the observation is in terms of sort of the clinical encounter, and my analysis starts the moment I see the person. So for example, in my clinic, when I was in my clinic in Montana, I would go out to the waiting room and greet people. I wouldn't have my staff bring them back to the room because I wanted to see how they stood up from a seated position. Did they struggle a little bit? Were they steady? How did they when they started walking, are they able to begin walking quickly, or is it jerky and unsteady? And I would have them actually walk in front of me for a little bit part of the way, so I could observe their gait.
Mm-hmm.
And I can observe whether their torso was kind of wobbling back and forth or twisting. And I can do that analysis while chatting with them and getting back to the exam room. And for me, this isn't rocket science. It is really very simple. And I think one of the challenges that we have in this country is there's a love of technology, that a lot of people think if I have the latest and greatest test, it's gonna change everything. And the reality is, with this condition, in terms of the predictive value of fractures and reversing fractures, every medical organization that's looked at the data have correctly concluded that fracture risk depends on factors largely other than bone density. And it's exactly what you guys are looking at. That one-legged stand, or another one is walking, across how long does it take them to walk, 6 meters, 18 feet, 20 feet, right? That sort of thing. This is really just about a lot of biomechanics, and then giving the body the raw material to do the job that it wants to do.
Yeah, totally makes sense. I think, part of that standing balance test, one thing that we're integrating and playing with right now is power production. But to me, power production is cool. We're looking at a little bit of vertical jump, how much power you can do. What I've always done back in my university days, when we were talking about hip fractures and stuff like that, my strength and conditioning coach was like, it's not your ability to produce power, it's your ability to put on the brakes. Like, you're not falling up the stairs and break. You're falling down the stairs. Can you stop yourself? Can you stop your weight on one leg? Can you take that knee impact? And I think that's one thing that, part of a really good design program is like, yes, we can resistance train, but can you put the brakes on?
I love that. That's really brilliant. I like the way you talked about that, and your professor talked about it. And I think you're right. Part of this is really, I think an excellent program is going to be strength, balance, and flexibility. And it's going to have all three of those components that you're improving simultaneously.
Yeah, I wonder, I guess the 10 pillars of fitness as it pertains to CrossFit, and I think Greg Glassman was onto something there. Well, really because he wanted it to be more of a health methodology, but I think it got lost in translation a little bit. But John...
if I can just say quickly on any strength training, there's also a real hole in how patients are being talked to their physicians about strength training with osteoporosis. There still is, and historically has been, a fear of telling patients to just go and lift weights. And because of the fear that stress on the bones is going to increase their risk for fracture. So typically it's moderate physical activity. Yeah. But there was a study that came out, the Lift More study you may be aware of.
From Australia,
High intensity progressive resistance training. Not going into the gym and just lifting the max weight you can right away, but focusing on perfect, really good form that's safe with a trainer, and then slowly progressing up in the weights in a very methodical fashion. There was 0 injuries in that program, and bone density went up, and the women actually got taller, and they compared to the control group, and they balance improved. Their ability to cross the room, like we talked about, was better. Their stand to sit timing was better, meaning how fast can you stand up and sit down over 5 seconds? How many of those reps can you do from a seated position? Improved. All indicators of strength and balance. And that's been replicated and shown in men as well.
Yeah. Yeah. And a lot of that study too, the program, I've reviewed it with a few of my patients and clients because I've had to put them on some things similar. There's axial loading, safe axial loading, right? Making sure we really compress that spine, get that brace core, really focus on like the law of radiation, just really pulling and creating turgor in the body. I think that's really important. And I think, sometimes the body just needs that external resistance to really force it to grow.
Yeah. I think the other thing too, like you just said, like the understanding of like progressive overload training in general is often, I think it's like just misconstrued from the average person, and being able to like effectively communicate that as like the fitness professionals that we are as well, because obviously we're not there to like go through it with them, but whether it's us recommending them to go get some like other person to have a watchful eye on them and explain to them, hey, overload could look like this, starting at a lightweight of 8 reps, even though you could do 12. And then next week you do 9 or 10, and then 10, 11, then 12, then you maybe add weight. But after that, like you gave yourself at least a month of that like getting used to it before you moved up, right? And I think so many people think that like more is better. If I do it faster or sooner, I'll get a quicker result. But ultimately, like if you kind of stay into it and that's part of your journey, and then you learn to enjoy the process, your outcomes are going to be significantly better. I mean, shoot, I've changed my thinking over the years too. I mean, starting as a young person that knew nothing essentially into, now being the spry young age of 32.
We're all babies once, Marcos. We're all babies once.
Yeah. But again, like it's, I mean, everybody wants to be like, quote, in better shape, or they're doing this because they think it's going to have that benefit. Hell, like I would probably look at someone that has those classifications if there's no other kind of cofactors going on or contraindications, and say, hey, like, have you heard of BFR? You're going to get a great, quote, stimulus. You're going to have this restriction on blood flow. And also the studies there, because it has not necessarily the mechanical tension of the lift, but it has some of the hormonal profiles getting there a little quicker, that you might actually see an even better improvement with bone density with some, not so common therapies.
I love that you talked about maybe going a little slower and not rushing it. I believe when somebody has the right process, the results take care of themselves. And I tell patients, look, this is, unless there's a medication that's destroyed your bones quickly, and they can destroy them pretty quickly, this is oftentimes a condition that's developed over many, many years.
Yeah.
And it's important to have a little patience and to get that program in place. That's not just exercise, looking at medications. There are other things we haven't talked about that are in diet, exercise, and other components that are really important to have on board to stack the deck in somebody's favor as much as possible.
Let's get into it.
What are other things?
Don't hold back, John. Let's hear what those next level of tips will be.
So one of those is stress. So chronic stress is unfortunately a big problem. People who are under chronic stress lose bone faster. And so making sure that there's a study that was done with healthy volunteers, and they didn't have osteoporosis, and they looked at their serum cortisol, and even those in the normal range, if they're towards the higher end of normal, they were losing bone faster than people who were in the lower range of normal. And so, making sure that your stress is, kind of under control, and there are different ways to do that. Sleep. People who get an average, 6 or fewer hours of sleep a night are at greater risk for osteoporosis. They lose bone faster. Making sure that you've got the nutrients on board to build bone is really important. I like for women, I know about half your audience you said is women, especially if they're getting their periods, they are at higher risk for iron deficiency, and deficiency in many different nutrients, minerals, vitamins, is associated with bone loss and osteoporosis. But iron is one of the things that I notice is missed a lot. And the best test for that is a serum ferritin test. A lot of times doctors don't quite know how to interpret it because the reference range is so broad as to be clinically ridiculous. I've seen reference ranges, quote unquote, normal as low as 10 all the way up to over 200.
Yeah.
I like administrating women. I want it to be closer to like 80 or 90. And a clinical trial actually showed that serum ferritin in women who had lower energy and lower mood, and their serum ferritin was less than 50. When they were given iron, it went above 50. All that improved.
Yeah.
So that's I think a really important piece of this. And then other supplementation, obviously calcium and vitamin D, making sure vitamin D is at least within the range of 30 to 44 on a blood test, because that is what's associated with the maximum hip fracture reduction. And I and other doctors like it even higher for immune health, but for bones particularly, that range, 30 to 44 nanograms per milliliter, is what is associated with maximum hip fracture reduction. Yeah. Making sure you're getting enough calcium, primarily, ideally through diet. You don't need getting more than the USRDA. There's no studies that have shown improvement in terms of outcomes for bones. You're talking with calcium and vitamin D about 18 to 23% reduction in fractures in osteoporosis. But then there's a specific form of vitamin K2 called MK4, 45 milligrams per day in divided doses, that in clinical trials have been shown not only to improve bone density, but more importantly, to maintain bone strength, as indicated by over 70% fewer fractures in clinical trials. And that's, 20 years ago, I created the first clinical trial strength of that MK4 in this country as a supplement because it didn't exist and I needed it for my patients.
Yeah, because normally isn't it MK
Correct.
Okay.
But MK7 has never been shown in any clinical trial to improve bone density. The studies show that it only slows down how fast somebody loses bone mineral density. And in one study, the women who took the MK7, they lost bone density faster at the hip than the control group. But more importantly, there are no studies showing that it maintains strong bones as indicated by fewer fractures. Fractures were never an outcome in any of the studies.
Okay.
So how do they study fractures in a study? Like, is it just like a one-off issue that happens? Like, or they try to break? Like, I mean, it's just like, it's like the coincidental, like, because again, that person, I mean, how many people are in these studies?
So it depends on the size of the study. I mean, there can be less than 100 to hundreds, but typically they're 2 years duration, and you're looking at baseline bone mineral density test. And then after 2 years, another bone mineral density test. And then during that time, they're being followed and monitored regularly. And if they fracture, well, there's a fracture.
Yeah. Okay.
Yeah.
And a lot of this is done overseas in other countries because they have much better surveillance data on patients. There's a centralized system for data collection because they have universal health care. And so a lot of these studies are done overseas because they're just able to track the data better.
Wow. Okay. So there's a little bit of a population, like, not proper correlation, I would say, then, right, with our population.
Not sure of the question.
Like, so it's in a different population is what I'm trying to say. So like they're doing it overseas, so it doesn't necessarily reflect our current US population, or we can correlate from that.
So that's an excellent question to ask. Like, okay, it was done in another population, so is it really applicable to here? Well, biologically, I've never seen any study showing that nutrients have different effects. So maybe there's different lifestyle effects and issues could play there. But now you're really getting into a very challenging area of teasing apart these independent variables. To me, what's clinically most relevant is that it's been repeated time and again in multiple studies in multiple different populations, that the biochemical mechanisms are worked out. They've been studied and defined. The clinical outcomes have been defined and have been repeated over and over in different patient populations.
Got it. That makes sense. Yeah, I only ask because, like, you made some really great points there for like the last few moments, and it's like, man, for the U.S. population, for John to go, really manage your stress. I really think it's a message that Marcos and I definitely recommend, but it's like something that we deal with so many patients, right, Marcos, that just come back and it's like, even though they did their annual with us or they did their thing with us, I'm like, they just seem more stressed and they seem like they may not be making the progress we were asking,
Yeah, well, yeah, but every year it's like it's a different version of the person. I guess, like, 6 years into this particular thing and this practice and understanding like what our niche is too. Like, also I'm like trying to think about it, like, granted my memory's not perfect, but I'm like, the variation on like hip scan for most people, like, if they're doing their training or whatever, it's, kind of nullified. But then there's also the element of like, we're doing HRT, Seamus. So like we're seeing a population that's not really indicative of exactly what, John's talking about too, because if there is a little bit of supplemental testosterone for a woman, especially if they did kind of fall into those ranges, how much is that helping, like with bone being deposited too? Makes me like, oh shit, like, I guess we have to take off our clinical hats of what we know and kind of throw it by the side, because not everyone's getting that same level of care.
Yeah, 100%.
Well, but I'm a fan of HRT. I think that's a really important component for a lot of people's health that they're not getting, both in men and in women. And in men, it's not just the testosterone. I mean, with andropause and the decrease in testosterone, it increases the risk for osteoporosis and fractures. But hopefully, people, if they're on testosterone replacement therapy, are also getting their estradiol tested, because it's the estradiol that is more anabolic directly for bone and for maintaining bones. So whether it's a woman or a man, that's an important piece of this puzzle. And I don't see things as either or, like, okay, we're only going to do HRT, but we're not going to do these other things. HRT in women is associated with a 28% reduction in hip fracture risk. So that's great, but we can do, I believe, much better than that through this multi-pronged approach. And HRT may be part of that for men and women if, when it's safe and appropriate. Supplementation for me is definitely part of it because of those clinical trial data. And I'll just, one more thing on those nutrients. I'm so convinced, and, having done this for 20 years and researched this and having the products on the market for that long and now different versions of it, that my company, I guarantee it, meaning that we guarantee within 6 months of taking any of our bone support products, somebody's bone density will stabilize or improve. But more importantly, any one of those 3 versions of the product will maintain strong bones, meaning if somebody breaks a bone, we will refund their money for all qualifying purchases between their bone density test results.
Wow. That's a really strong offer. I mean, John, I think we're at a good time for this. I think maybe we'll transition it here because I hope the people took notes, transcribe this because this is really good talk. I mean, this is the stuff that we're inundated with daily. So I love that the audience is getting this. But let's talk about your company, Nutritional Biochemistry. What are like the best key offerings that you have? Like, what are the best sellers that people get, or what you usually recommend? And talk about that for a second.
Yeah. So I started this, like I mentioned before, out of my clinic because I could not find the doses of nutrients shown in clinical trials to work that I needed for my patients. And so a lot of my products come with some very unique guarantees because they have the clinical trial doses in them. You can test and they get repeatable, consistent results. So for example, my iron dietary supplement for people who need some extra iron. We talked about ferritin, guaranteed to improve ferritin on blood tests. It's the highest dose ferrous bisglycinate form of iron on the market, 45 milligrams, but importantly, guaranteed not to cause cramping or constipation, which is a real problem for these other supplements. And that's why I created it, because of all these complaints I was getting. Bone support is our biggest niche in terms of our products. And that's the Osteo-K, Osteo-K minis, and Osteo-MK4. The only difference is the amount of calcium, because not everybody needs the same amount or any calcium as a dietary supplement. I'll come with that strong bones guarantee that I mentioned. Sleep, huge problem. Also one of our better sellers. It's the only time release biphasic tablet on the market. So I created a product that has a phase 1 releases its nutrients in about the first 30 minutes to help people fall asleep. Phase 2 over the next 4 hours to help people stay asleep. Or if they wake up, they can more easily go back to sleep.
Ooh.
And they just wake, it wears off in the morning and they wake refreshed. There's only 1 milligram of melatonin per tablet.
I love this. I love this. Like you can't run the pineal gland to the ground. So like I love what you're doing. I've never heard of a biphasic market. Like, I'm being honest with you. I'm like, I love sleep supplements. So I'm gonna have to
I know. I want to see what your formulation looks like. Now I'm curious.
No, me too.
Yeah. Pull it up. If you want some samples, I'm happy to send you some to try. And I do that when I go to conferences. There's certain products I bring cases of product, and I just give away to clinicians to try. They feel good products like sleep relief. They'll come, calm and clear for stress.
Could you talk about why only 1 milligram of melatonin? I think, melatonin is this thing. I still think that melatonin, anything, in my opinion, anything about 3 grams, anything about 5 grams, it's kind of like a super dose on the brain, in my opinion. But why did you keep it at 1?
Yeah, so the body's use of melatonin is primarily for sleep initiation or sleep onset. And it sort of peaks at about 10 p.m. or it starts to increase at about 10 p.m. and then peaks at 2 in the morning. And so we don't produce milligrams worth of melatonin. People tend to take higher and higher doses because it has a short half-life, meaning 50% of it is out of your system within an hour, and then another 50% the hour later. So people take it, they wake up in the middle of the night, so they start taking higher and higher doses just to knock themselves out. But that's not how it's used in the body. So I really looked at the endocrinology, the biology of sleep and what we know at this point, and tried to mimic that and replicate that. And so I can support and promote those different phases of sleep at different stages of the night.
My next question is, though, is it a proprietary formula? Sorry, I just have to ask.
It is.
Okay. That's usually like the hardest thing to try to sell people on for me, because I want the transparency personally. But
I'm happy to tell you what's in it.
Okay. Well,
yep. The reason it's a proprietary formula, because if you look at the size of the bottle and the label, couldn't get all the ingredients listed out individually on that label. And I didn't want to put it in a larger bottle. But there's 1 milligram of melatonin in it per tablet, 250 milligrams of tryptophan per tablet, some B6, some B3, ashwagandha, jujube, hops, gutalaria, different herbs, all great nutrients.
Yeah.
GABA, glycine.
Yes.
L-theanine.
It's like everything's there, but of course, like what's the word? The person in me that always wants to just kind of know everything. Because again, like obviously, not to say that I don't trust you, right? But like the clinically backed dosaging sometimes, like if the labels don't, disclose that, then you don't really know what you're getting. But for you to be like, hey, I'll tell you what's in it, because like I just wanted to keep the bottle like more compact for people, that makes total sense.
Yeah.
Well, and I love that you said, you want to know, and it's okay that you don't trust me. fact, when I get up and give my medical talks, I tell the clinicians, all the citations are here. I encourage you to go and verify everything that I'm saying and learn. And I'm happy. I am an open book. And this is another thing that really upsets me is sort of a side note with the dietary supplement industry.
Yeah.
Is that you have companies that aren't transparent. We will give, if somebody wants a certificate of analysis for a lot, to show them that it's been third-party validated and tested for all the nutrients and the dosages, and it's clean, it's clear of heavy metals, it's clear of microbial contaminants, we will give that to them. And I'm telling you, people over and over come to my company and they're like, well, I've asked other companies and nobody will give it to me. Like, why not?
Yeah.
It's what I would want.
Exactly.
Yeah. No, I love that. That's so awesome.
Well, and again, I think that's like lets me rest assured essentially, because it's like, as our physicians want us to go vest certain things, like, hey, you guys probably know more on like that industry than us, because we're like, prescribing more on the medical side. And yes, there's supplementation side, but like, can you guys go also be a liaison and understand? It's like, yeah, I want transparency. I want to be able to note that, but for you to also say like, I want you to kind of question me, helps me feel really like happy as well. Like, because obviously it's what we look for, because if Seamus and I are trying to recommend something, we want to try to back those things with the research, because that's just who we both are. We're more science-based in that sense, because so many times we feel like people have come to us and they're just getting duped. They're like, I heard this thing was good. I got it on Amazon. We're like,
how many times has that happened in my life?
Hundreds at this point.
Yeah, I think, all three of us, I think I approach this very similarly. I want to know the details too. And I want to know that what I'm recommending, that I vetted and that I can trust, and that I know that it's the right choice for the person.
Yeah. No, I love it. Marcos, any last questions? We are over an hour. I just want to make sure I'm respectful of John's time.
No, I mean, would love to sample. I've actually not ever taken any melatonin, Seamus. I know you probably don't believe that, but that's like the one thing I haven't dipped my toes in.
You know what's crazy? Can I just pause you for a second? Like melatonin, like I have to reference the study. The reason I'm kind of like very wary of melatonin is because when I was talking to that same professor, he like referenced a study back like from the military, like back in the 40s or something like that. He's like, they did the study and they did melatonin with them. I don't know the dosing, but 3 months later, everyone was dead. And I was like, what? It might have been like a fear tactic that he did with me. But I think melatonin is so great. I just think the higher doses for me are just, I don't take anything above 5. But there's a lot of things like the ollies at Target are like 10 milligrams. And I'm like, what?
I know. Like, people are giving that to their kids in gummies, dude. That's why I'm like super skeptical about it,
Yeah, for the general public, I mean, taking that amount, I'm not a fan of. I think that for bone density, and back to the osteoporosis piece, there was a clinical trial in women with osteopenia or pre-osteoporosis that showed that 1 and 3 milligrams of melatonin both improve bone density, 3 milligrams being better than 1 milligram. There are melatonin receptors on bone, just like there are serotonin receptors. There are oxytocin receptors. Our osteoblasts produce oxytocin. We didn't even talk about community. You talked about the blue zones and how people are there eating and walking. They're walking more. They're also eating more in community. Social networks are important.
Yeah.
And that is actually associated in studies, a strong social network, if somebody were to fracture, with better fracture recovery and also lower risk.
Because they're with people. Wow.
Lower all-cause mortality. So I think that all these things are integrative, are sort of intertwined. With respect to the melatonin in oncology settings, I know a lot of integrative oncologists, they'll use 20, 40, 60 milligrams. And so certain clinical settings, there is good reason and good research for using very high doses. For the general average person out there, they're getting these doses that are sold are too high.
Got it.
Yeah.
Oh, that's crazy. Marcus, you want to ask a last question here, or maybe just wrap it up?
Now, no more last questions. I think those particular components of it are what we continue to strive to do and provide in terms of information, like understanding all those parts of community, the different pillars of health, as we so call them, right? Every different person or company will probably have their own thing, because that's kind of what you do. You come up with ideas and you try to frame it into that. And then we got our big 5, and the idea behind the community side of things was a great way of summing it up and talking more about like quote unquote the family sector that we've talked about on our podcast for a number of years now, which is cool. So like you just said, it's very much a synergistic approach. It's not like a one size fits all kind of thing. It's definitely you want to figure out all those individualistic components and tie them together and get down to the root cause. Like, when you opened up with that, aligned with both myself and Seamus, and kind of, why we started this venture in the first place. So thank you for, shedding light on bones, and a topic that I think so many people potentially get a little bit scared about as they do get, to their older years. And, I'm a huge advocate for letting people know, like, hey, like if you've been listening to us for a while and you want to like kind of get a baseline at a younger age, maybe you're in your early 30s, probably a good time. I think it's never too soon to like look at that so that you know where you're starting versus, jumping the gun and thinking like, hey, this is where you were, even though you're 50 years old. So, I hope that more people can get started earlier with understanding how to be proactive versus reactive. And John, I mean, if there's anything else that you want to like, just share right now as we wrap this up, that'd be great. And then I'll just say our last closing remarks.
I love your approach. And there are a lot of reasons why people should be getting tested earlier, and things that put them at higher risk for osteoporosis. And sometimes osteoporosis is referred to as a pediatric disease with geriatric consequences. The peak bone mass occurs when people are in their 20s. And there are a lot of things that can interfere with that, especially in athletes and female athletes, a female athlete triad that I'm sure you're familiar with, right? Where they don't achieve that. So getting that baseline younger, I think for a lot of people can be very instructive, especially if they have a history of eating disorders or extreme athleticism, if they're on a vegan or vegetarian diet, which are associated, with higher rates of bone loss and osteoporosis, different medications that we talked about, all of that. So I think our approaches and the way philosophically and based on the research that all three of us approach this, I think is very much aligned. So it's refreshing to me to speak with you about this, because you both already know a lot of these things and are already doing them with people. So I think you're doing a huge service. If I could just add, I would like to mention my website where people can find out more, nbihealth.com, nbihealth.com. Lots of free articles on there. Just put in a search term, probably turn up something that you're looking for. My products, the research, it's all on there.
Yeah. And it was super simple to find. I just typed in NBI sleep, right as you mentioned that, just so I could take a look and peruse the website real quick. Super easy to find and navigate. We'll have it listed below so you can find that if you're looking for particular, things that have a really great guarantee. That's really cool. Like the way that you explained that. And, again, everybody, thank you for coming into, another episode of the Macro Perspective. We continue to get great guests on. We would really appreciate your support. So if you can drop us a like, a comment, a follow, all those things would, be near and dear to both mine and Seamus's heart, as obviously this podcast actually costs us money to do, and we do it for, bettering the minds of everybody else around us. So until next time, Macro Perspective peeps, we are out.